Hello, I'm John Conroy. I'm one of the consultant orthopaedic surgeons at Harrogate District Foundation Trust, and I'm a specialist in hip surgery. I've been trained in hip surgery over a number of years and started as a consultant here in 2006. My training has involved time abroad in Canada, Australia, and I've a particular interest in hip replacements and also soft tissue sports injuries in the hip. The reason you've been referred to outpatient clinic here at Harrogate is generally because you have pain around the hip area. Now, pain in the hip isn't always exactly where people think it may be, because the hip itself has a low concentration of nerve fibres, and so patients can present with symptoms in the lower spine, the side of the hip, the groin, or refer to the knee. So it can be quite challenging to work out exactly where your pain is coming from and how we treat it. You will be asked questions such as, do you have problems putting on your shoes and socks or cutting your toenails? Because this picks up some of the functional problems that you might have with osteoarthritis or pain in the hip. So if we do ask you some funny questions, that's the reason behind it. But for most people, they will present with pain in the hip, which tends to be the groin radiating to the thigh and down to the knee. And they'll also notice that they've got some stiffness in the hip area. So they may have noticed a really slow onset of difficulty getting dressed. And associated with this, there might be problems with functions such as walking upstairs, walking longer distances, lifting, carrying, those kind of things. So you will have generally been seen by your GP and maybe a musculoskeletal physiotherapist, who in most cases will have excluded non-operative techniques to control the symptoms, such as exercise, which we would thoroughly support. You can take anti-inflammatories such as ibuprofen if you are able to take anti-inflammatory drugs and have no contraindications. You may find that you've been offered a steroid injection, which can, in some patients, really help the symptoms. Steroid injections can be effective if you have very mild arthritis and can last for a long period of time, but the effects of a steroid injection is very dependent on several factors, and some patients find that they may not work or they may only last for 1 to 2 weeks. So do discuss injection with your surgeon. And if they say you're not suitable for an injection, it may be because the severity of your osteoarthritis means that it will be less valuable for you. Other things you can do before an operation is generally look after your general health. So if you smoke, consider stopping smoking. If you're overweight, consider reducing your weight, and try and eat healthily, make sure you get plenty of rest and sleep, and generally look after yourself. Because if you are having an operation, you can plan to be as fit as possible before that operation, and it gives you the best possible outcome in the recovery. We know that fitter, slimmer people tend to recover quicker and have less complications after surgery. So for patients who need to have a hip replacement, they often ask me, when do I know whether I need a hip replacement or not? And the crucial factor about a hip replacement is it's a quality of life operation. So it's very rare that the surgeon would ever say to you, you have to have an operation. It's about balancing the risks and benefits of the procedure. And so most patients get to a stage in their life where the symptoms are affecting their sleep, their ability to spend time with their family or interact with children, their grandchildren. They find that they can't do their hobbies, they may become socially isolated because they're not getting out of the house very much, or they may find it's affecting work. And you will get to a point where you will know that it's the right thing to go ahead and have surgery. Once you've made that decision, it can be quite an anxious time for patients because you do worry about complications and if something goes wrong, what kind of effect can that have on you? Now, looking at all operations, they all have risks, but a hip replacement is one of the most successful operations that we do. And generally, we would quote that 95% of people are happy with a hip replacement. But do dwell on the positive side of it. 95% of people are happy afterwards, and in most cases your hip replacement will last you for at least 20 years. So in 80% of patients we can be confident that your hip replacement will still be functioning after 20 years. The new technologies in hip replacement have allowed the hip replacement to last longer, and you're also able to do a lot more activities that maybe patients in the past have told you that they wouldn't be able to do. So your surgeon may be happy for you to walk good distances, return to golf, return to swimming. You may be able to play competitive sports such as tennis. You should be able to play golf. I personally allow my patients to go back skiing and even light jogging. And so it really does depend on the discussion that you have with your surgeon and what they're happy for you to return to. But also, I think as a patient, you have your own ability to balance the risks of more wear within your hip replacement compared to the activities that are important to you in your life. So when you make the decision to have a hip replacement, you will be a bit anxious, and the anxiety is generally related to coming into a hospital, into an environment you're not used to, but also in the back of your mind you will have concerns about potential risks of the surgery. In my practice, I will give you an information booklet which will go through the risks of your operation in detail and allow you to have a chance to read those risks at your own leisure at home. But some of the common risks with hip replacement are risk of deep vein thrombosis or pulmonary embolus. There's a risk of approximately 1 in 1,000 of death from a pulmonary embolus after a hip replacement. And we try and reduce those risks by putting you on anticoagulant therapy after your operation, which in this hospital tends to be injections for 28 days after your surgery. The risk of infection is another major concern, and the risk of infection is quoted between about 1 in 50 patients to 1 in 200 patients. If you have an infection, it can be a simple superficial infection that will respond to antibiotic therapy and won't cause you a problem over the longer term. But if you have a deep infection where the infection can become adherent to the implant, it's possible that you would need a further procedure to remove your original hip replacement. You may require antibiotics for up to 6 weeks, and you may have to have a further procedure to have a new implant placed in. So that's a really significant risk that you should at least reflect upon before making a decision. There are risks including dislocation. In the first 3 months after your surgery, your risk of dislocation is higher than it would be after that. So it's important when you first have your operation to follow the instructions of your surgeon and the physiotherapist, just to be careful about the activities you do in the immediate post-operative period, and to slowly introduce activities over 3 to 6 months. It's important that you realise that no matter how well you feel, your tissues in the hip have got to have time to heal. And no matter how fit you are or how active you are or pain-free you are, your tissues still need at least 3 months to get solid and heal properly to reduce your risk of dislocation. So please be patient with your recovery. With most operations there are standard risks, and some of the standard risks include bleeding, which in rare situations you may require a blood transfusion. There's a risk of nerve injury, which in a small amount of cases can be significant and leave you with ongoing pain or weakness in your leg. There's a risk of fracture. If there is a fracture during the procedure, that's a low risk, but if it occurs, you may require fixation of that fracture during the original procedure, or you may need to go back at a later date for another operation. There are risks including leg length discrepancy that people are particularly worried about. And with a hip replacement, it can be difficult for the surgeon to balance your hip correctly during the operation. And this may be related to other factors such as the shape of your spine, your natural leg length before the operation, So some patients naturally have a shorter femur or tibia on one side compared to the other, and it's not until you've had a hip replacement that increases your leg length by a small amount that can be much more noticeable for you. Often, if you do have an increase in your leg length, or you feel an increase in your leg length, over the following 6 months after a hip replacement, this can settle down and not be a problem at all for you. After a hip replacement, you will be expected to be in hospital for a certain amount of time. Most patients are admitted to surgery on the day of surgery, the morning of surgery, and we would attempt in most fit and active patients to get you home the next day after your operation. Depending on any other issues that you may have, if you have other medical concerns or you have poor mobility anyway, it's possible that you'd be in hospital for longer. There are real benefits from getting patients up and active after the surgery immediately, as it reduces some of your risk of complications such as deep vein thrombosis, pulmonary embolus, chest complications. And we know that people who are active quicker from surgery tend to have a better long-term result and have a more satisfactory outcome from their surgery. Most patients will have a spinal anaesthetic with associated sedation, but the choice of anaesthetic will be discussed with you by the anaesthetist on the day of surgery, and if you have any strong feelings about the type of anaesthetic you want, you will have that ability to discuss that with the anaesthetist. For the patients who have a spinal anaesthetic, it will take several hours to wear off after your operation, and it may not be till later in the day or potentially the next day until you're able to get out of bed and mobilise. And it's really important that you only get out of bed after you've informed the nurses or the physiotherapist has come to help you get out of bed. Some patients feel quite faint or dizzy immediately after the surgery, or you may feel that your legs aren't strong enough to hold you. So please don't jump up and get out of bed unless you've discussed that with the nurses or the physios on the ward first. Now, after your operation, it is likely that you will have some pain, and the nurses will keep an eye on your pain, and they'll measure your pain scores, and they'll try and balance the amount of pain that you have versus any complications or downsides of the painkillers that you have. Some people can feel quite sick or nauseous. Some people can feel lightheaded with painkillers. And so there is some fine balancing over the painkillers. So please be patient with the nurses so that they get that balance right for you, so that we control your pain, but also don't leave you too drowsy or feeling unwell from the side effects of the painkillers. Now, before you go home, we will check that you're able to walk upstairs safely, and we'll make sure that you're safe to go back into your home. And by the time you're signed off by the physio, we'll be confident that you're in a good position and a safe position to return home. So please don't be worried about your ability to get home, because it will be assessed thoroughly, and often it can be quite daunting for you immediately after your operation because you think you're not going to achieve it, but you'll be surprised to know how quickly you will get confidence in the first 24 hours after your operation. On discharge, you'll be either discharged with a walking frame, sticks or crutches. Most of our patients will be discharged home on walking sticks, and we would normally recommend that you're on these walking sticks for approximately 6 weeks. After a period of 6 weeks, you may be in a position to return to driving. You may be able to discard the sticks at home once safe, but you will be given guidance on this by your physiotherapist. So 6 week stage is a major milestone after a hip replacement. Not everybody will be off the sticks at that stage, and not everybody will feel confident enough to drive at that stage. And please don't judge yourself with other people. Some people take a little bit longer than others. Some people recover really quickly, and after just 3 or 4 weeks may feel confident to mobilise more freely. The next milestone is the 3-month milestone. The 3 months milestone after a hip replacement, I'd be expecting that patients could start returning to activities such as golf, longer walks. You'd be more confident about driving, and I would expect the vast majority of patients to have already returned to work at this stage. You will be reviewed in the longer term in most of the clinics by a nurse-led clinic, and you may be referred for an x-ray, and that will be arranged for you to come back into hospital. Not all surgeons would recommend that you need to come back for a clinic appointment, and you may not require a further x-ray, so don't be concerned if you are discharged shortly after your stay from hospital. It's important that the risks we've discussed today are also compiled with the risks that are in the written information that you're given, and I would thoroughly recommend that you read this before you sign the consent form, either in clinic or on the day of surgery.